So hi, everyone. My name is Amanda Billups, and I'm the Senior Manager of Nursing Ed. Thank you so much for coming here today. We have an amazing presentation. I hope that when you're sitting through this presentation on solid organ transplant, that you don't just say, oh, this is just one unit or a couple of units in the hospital that takes care of solid organ transplant, because we all are impacted by our solid organ transplant, whether you're in peri-op, whether you're med-surg, telemetry. You can think that maybe the person in that bed may be a potential donor. All right, maybe that person in the bed was a recipient of an organ. And when we say solid organ, we mean heart, liver, lung, and kidneys. So we're going to be going through our program today with you all, and the journey that we really started from the ground up here, and the innovation that it took to get this off of the ground is nothing short than amazing. And it's because of this team, the collaboration with our ACPs, with the coordinators, with the nursing, with our quality, has led us here, and we are just extremely proud to present this to you today. So without further ado, I'm going to introduce the first presentation, which from our 6-month nurse, Tatiana McAdler. Thank you, Amanda, for that lovely introduction. Again, my name is Tatiana McAleer. I'm very excited to kick off. Welcome to Nursing Grand Rounds. Today, we are here to talk about the solid organ transplant program here at North Shore University Hospital. We have a group of wonderful presenters here with us. We have Nora Brady, Yoonjun Kim, Tatiana, me, Melissa Hill, Jamie Hannigan, Colleen Flores, Rebecca Vogatura, Valerie Demikin, and Nicholas Jandovitz. Here we go. Just an outline of our objectives today for our presentation: learning about the Northwell Health Transplant Institute and plans for future growth, to understand the regulatory framework for organ transplantation and living donation, understanding the interdisciplinary team that is involved in a transplant patient's care, big, great team, learning the process that patients undergo both pre and post organ transplant, learning the differences among the organ transplant services here at North Shore University Hospital, and understanding the referral, donation, and allocation of deceased donor organs through Live On New York. And a little outline of our agenda here. We'll be starting with information about the Transplant Institute, regulatory framework, evaluation process and phases in the selection committee, pharmacology, then going down kidney, liver, heart, and lung, operating room considerations, organ donation, allocation, and Live On New York, and closing up there. So we have a very excellent presentation, an hour packed of fun information. I'm going to pass it on here to Nora Brady.
I'll be quite brief because obviously there's a lot to cover today, but just want to kick off to share a little bit about the transplant programs today, where we've come and where we're going. So starting in 2007 with Dr. Momenti, who's here in the front row, we kicked off our adult kidney transplant program at North Shore. After some time building out our adult program, we launched the pediatric kidney transplant program in 2017 at Cohen Children's Medical Center. Shortly thereafter, we opened the heart transplant program at North Shore, the first and only of its kind on Long Island. And then towards the end of the year in 2019, we launched our adult liver transplant program. Most recently at North Shore, we started our growing adult lung transplant program. Again, the adult liver, lung, including heart, these are the only of its kind in Long Island and our surrounding communities, which is a tremendous feat. And as you see here in 2023, pediatric heart transplant program at Cohen Children's Medical Center is underway, and more to come. Anyone in transplant, which is everybody here, and including on the line, knows there's always something coming next. So I'll just jump to the next slide. Quickly, you'll see the progressive growth. This is abdominal, and I'll jump to the next slide on thoracic. Year over year, really for all of our programs. And it's a remarkable achievement that we've been able to provide complex, life-saving care to a significant number of people in need within our communities. In addition to the acute care that you are all part of here in the hospital, so that patients can receive the care they need in a timely way, it's critical that we've really been able to provide care for patients throughout their entire care continuum in transplant, their outpatient appointments, their testing, the labs that they need run. When you think about a transplant patient that you all have experienced, it is a lifetime sense of care, and they need so much throughout the community. So to think that we can offer these things on Long Island and provide exceptional care is such an achievement. And so transplants is team sport, as Amanda alluded to here. We all firmly believe that we can all provide that exceptional quality care throughout the system in a convenient and efficient way. And that's really part of our mission. So again, to the thoracic programs, just significant growth and incredible outcomes in such a quick but efficient and thoughtful way. So it's a credit to everybody on the call, everybody in the room, and everyone that touches a transplant patient in the Northwell Health System. Although this is in no way representative of the entire transplant team, everyone felt that it might be helpful just to give an overview of some of the key physician leaders associated with our programs. We're joined gratefully in person by Dr. Momenti today. But just to get a sense of kind of the who's who, both here at North Shore and then at Cohen Children's Medical Center. And so this is very detailed, but just to briefly go over some highlights of where we've been and where we're going for each of these programs. So the kidney program, its most recent expansion, just I want to call out, is really partnering with organizations like National Kidney Registry and Renewal to continue to grow our living donor program. And you've seen we've made quite a number of milestones since our inception back in 2007. The heart transplant program at the Sandra Atlas Bass Heart Hospital has made tremendous strides since its launch in 2018, and they're soon to be joined by the pediatric program at Cohen Children's Medical Center. The liver program has witnessed significant growth in the last year or so, which is complemented by the development of a living donor liver transplant, which we hope to perform sometime later this year at North Shore, and soon a pediatric liver transplant program at Cohen Children's Medical Center. Lung transplant, the most recent transplant program at North Shore, is quickly becoming a really established program in the transplant community and solidifies our identity as a full-service transplant center. Low volume, but yes, there is pancreas on this slide. Sometime in the near future, we are hoping to also offer pancreas transplant here at North Shore University Hospital, which is really exciting, just building upon all of the momentum that we've done so far. With that, I will turn it over to Colleen Flores, our Director of Regulatory Affairs and Quality in Transplant. Thank you.
Thank you, Nora. Good afternoon, everyone. So I'm here to speak about the regulatory framework. Just a note, Congress established the transplant system in 1984 with the National Transplant Act, otherwise known as NOTA. In the face of organ shortage, NOTA established a registry for organ matching. The purpose is to provide fair and equitable access to transplantation and to forbid the sale of human organs. Congress called for the network to be overseen by a federal contractor, and in 1986, that contract was awarded to UNOS, located in Richmond, Virginia. They hold the contract today. UNOS can and does occasionally report to Congress. An image here is the CEO reporting at a congressional hearing last year. You don't want to be in that seat. It's a very difficult position. We must apply for each hospital. So we actually have to submit a blueprint of our hospital and our ORs to satisfy the requirements to hold a transplant program. And it's a very unique privilege. With over 6,100 hospitals in the United States, only 4% are permitted to perform organ transplant. So it's a very privileged status. In the 2000s, investigative reporters at the LA Times demonstrated probable voids in the oversight of transplant programs. One case from St. Vincent's Medical Center in LA involved a surgeon who accepted a liver from one patient, but transplanted the organ into another patient who was lower on the list. They lied about it in the process to UNOS. In subsequent data submissions to UNOS, St. Vincent's continued the falsification, and at least 7 employees participated in the cover-up. A review identified an atmosphere of fear and retaliation as reasons for the widespread falsification. The media caught the attention of Congress and eventually led to the development of hundreds of regulations from CMS, UNOS, the New York State Department of Health, and Joint Commission, which we adhere to today. Often the regulations align with each other, but in several key specific areas, they do not. Okay, guys. Brilliant. Thank you, Nora. So the regulations are constantly evolving with aim to improve transplantation for the patients and donors and their families that provide the gift of life. One of the main pillars of the transplant programs is the ability to accept organs and perform surgery. Also address patient issues 365 days a year, 24/7, thanks to our OR. In fact, we are required to formally inform our patients and the government if we cannot meet the standard. Also, to ensure 24/7 coverage, our primary surgeon or our primary physician cannot be primary for another transplant program unless we have explicit permission from UNOS. Patients are provided with a written summary of this coverage plan. A transplant program's regulatory framework is composed of what Dr. Donabidian out of the University of Michigan referred to as 3 pillars of healthcare quality. So we have structure. I think I've shown that to you now. We have process and we have outcomes. Here's a list of our processes that we have. Each program has this. I won't read these, but I'll comment that each agency conducts compliance surveys or in the face of a patient complaint warrants a review of each of these processes. Consequences of noncompliance with these processes can mean an on-site survey, probation, and or even closure of a transplant program. How do CMS, UNOS, patients, the government, transplant centers, and private insurers know our outcomes? Anyone, anywhere can see our transplant program outcomes, both pre, peri, and post-transplant outcomes. Program data is publicly available through the Scientific Registry of Transplant Recipients. And because of these reports, we know how we perform compared to any transplant program in the country, and especially the region, and why we can claim in 2022 that we had the #1 patient survival at North Shore for our kidney transplant patients. How do we maintain these outcomes and adherence to these regulations? Well, transplant programs required by the regulations must have comprehensive data-driven quality improvement programs integrated within the hospital quality program. Our quality committee includes members of every discipline a patient may encounter and covers the entire patient journey. Many of the members are here today and you'll hear from those members as well. And however complicated it may become, we follow that journey. So these rules can be complicated and sometimes confusing. And just like this map and the landscape, the routes can change often. These regulations cover every aspect of the patient and the organ donor journey. Experience helps, and that comes with time and sometimes mistakes. At North Shore, there is a combined experience in our leadership of over 200 years in organ transplantation. The positive outcome of this oversight, rules, and regulations is improved outcomes for our patients and their families and equitable organ allocation. Compliance requires knowledge and constant vigilance, and we need your support. Thank you so much. Thank you. Now I'd like to welcome Tatiana back to talk about our evaluation phase. Thank you.
The evaluation phase begins when a patient is referred for a transplant evaluation. The transplant team must determine the candidacy. Not all patients are eligible for transplant, hence the need for an evaluation process. Each patient begins by signing a consent for evaluation prior to the start of the evaluation. Each program has specific criteria to be considered for organ transplant, and each program has absolute contraindications and relative contraindications. A multidisciplinary system is used to evaluate thoroughly the potential transplant candidate. including factors that may affect both pre and post-transplantation survival and quality of life. Patients undergo a thorough medical, cardiac, surgical, nutritional, pharmacological, and psychosocial assessments. They also require financial clearance. The multidisciplinary team members, as you can see listed here, begin with our transplant surgeons, our transplant coordinators, our transplant physicians, our hepatologists, nephrologists, cardiologists, and pulmonologists, transplant social work, financial coordinators, mental health therapists, registered dietitians, transplant pharmacists, anesthesiologists, and any consult specialty that is necessary for the individual, as well as the independent living donor advocates. Many different tests are performed to determine if a patient is a suitable candidate. These tests may include, but are not limited to, lab testing, determining blood type and screening for infectious diseases or specific viruses, urine tox screens, PPD quantiferin gold tests, abdominal imaging, MRIs and CAT scans, cardiac testing, chest x-ray. We have our PFT testing. Those are for our lung transplant candidates. Carotid Dopplers, mammograms, endoscopies, colonoscopies, cancer screening, dental exams, and consultations with any other subspecialties if needed. So very extensive, important, and really, touches upon everything and anything to make it a successful transplant. I'm going to hand it off now to Ms. Valerie for one of our pharmacists.
All right, so now we're going to get to pharmacology, which is a very important aspect of transplant patients' care because every patient will take medications. So before we transplant anybody, every patient gets a financial counselor. We'll review the chart and particularly we'll focus on the insurance aspect, which is extremely important, as you can imagine. If it's you have to be in the situation, like you want to make sure you can afford something or some sort of care that you gonna receive. So what doesn't imply, and I guess what questions you might receive from the patients on the floor when you take care of the patient who is going through the evaluation would be, what would be my out-of-the-pocket cost, which is like very common question, or does my insurance cover certain medications, or do I need any supplemental coverage? So in this case, our team, any lung transplant, heart transplant, liver transplant, kidney transplant team will be able to help you out, and financial counselor can help those patients to answer those questions. In addition to that, we also utilize heavily specialty pharmacies. One of them is Viva Specialty Pharmacy, which is part of our network, and most of the patients will receive prescriptions from those pharmacies. So anytime you have a discharge for transplant patient going home, even from internal medicine floors, you want to make sure that the patients have ability to get their medications and they can sustain their therapies while they're outside of the hospital. Nora, what did you press? I tried it all.
Double it on T.
Oh, okay. Perfect. Okay, so what the pharmacists look for when they evaluate each patient. So before they list a patient, each one of us will go through different consultants, right? And one of the aspects would be medications. From pharmacist standpoint, what we look for, if anybody is on anticoagulation, on antiplatelets therapy. So if you imagine it's a major surgery. So as you can imagine from any procedure, a lot of times we hold those medications, right? So now you have patient listed at home and they're taking apixaban, right? So that's something cannot be easily reversed, and your surgeon was not going to be happy with this patient, right? So a lot of times in this case may be aborted as well. So we try to put the patients on therapies such as Coumadin that we can easily reverse. So that would be one of the examples that pharmacists will make intervention and make sure that the patient is safe while they're listed, but also when they receive a transplant. Opioids, benzodiazepines, and illicit drug use. So illicit drug use, if somebody's using drugs illicitly, it's one of their contraindications to the transplant, and we kind of work with the patient to make sure that we put them on a safe path before we list them for transplant and transplant them to avoid any of their issues post-op, right? And there are ways to do it, and obviously the transplant team can help those patients as well. For opioids and benzos, specifically for lung transplant, we try to minimize their use significantly because it affects their breathing pattern. So if you know, a lot of patients get overdosed at home and they stop breathing, so that would be one of their kind of contraindications. We make sure that we do it safely and we taper their therapy before they're listed for transplant. Amiodarone is specifically contraindication for heart transplant because it has mortality rates post-transplant because it causes bradycardia. So if you think about it, heart is not going to be happy if they're bradycardic, and it's a long half-life, so it stays in your system for quite some time. If anybody's on chemotherapy, it all would be evaluated by oncology team, and it's all risk versus benefit, like how risky it is for the patient to be listed for a transplant. But it's one of the things we are looking for because as you imagine, if you take immunosuppression therapy, the cancer for the patient can start rapidly growing, right? So that would be one of the contraindications to be listed for transplant. And I'm sure somebody will comment on that part. And biologics, if somebody's taking it for whatever diseases they have that can put patient at risk for extra risks of infection, or the immunosuppression needs to be adjusted. Vaccines, cannot stress enough about that. And we always look for our nurses to partner with you guys to make sure they're administered. But I just want to take a few seconds to explain why. So every patient will get through, like when they get through the transplant, the immune system would be suppressed. So they're going to be a very high risk of infection, right? When you give them vaccines post-transplant, they don't get the same response as you get right now. So we want to maximize their post-op care, give them vaccines now. So when we order them, and if you imagine vaccines, usually not just one time, it's usually serious, right? So remember when we got COVID vaccine, we had to come back in 30 days, right? So that's the same thing. When we give vaccines, we start them as soon as possible. We want to kind of expedite it. We want to move with the process so they can get all their series before the transplant is done. We still can vaccinate patients post, but it's something important to do. So when you see it, please help us out and administer them as soon as possible. We don't wait for the discharge because a lot of those patients actually will never leave the hospital while they're waiting for transplant. Okay, and vaccine, just one more aspect of that. To help our providers on the floor, we actually partner with Transplant ID. So infectious diseases doctors, they review what patients need based on their serologies, based on the history of the vaccines. And then some of the vaccines actually can be dangerous for the patients when they receive transplant, such as live vaccines, right? And if somebody, for instance, received a live vaccine, we can list the patient for 30 days before while they are at very high risk to actually acquire that virus if they're immunosuppressed. So the bottom line is call your team. Transplant team will help you out, including the Transplant ID. They're your friends in this situation. And those are kind of examples of the vaccines that we commonly administer to the patients. On this note, I'm going to transition to immunosuppression, and Nick Jandowitz is going to talk about that. Thank you for your time.
All right, so we're going to move into the post-transplant phase now. So with immunosuppression, we have two phases, an induction phase and a maintenance phase. So your induction phase is usually a non-lymphocyte depleting or a lymphocyte depleting agent, Similac or thymoglobulin here. They're a short period of medications. Then after that, we're going to move into the maintenance phase, which is what patients are going to be on for life. That's what you're going to see here visually. They're kind of on it for the rest of their life here. The calcineurin inhibitors, tacrolimus and cyclosporin, are our gold standard of therapy here. And over time, we're going to target lower levels, but they're still going to be on these medications. With your mycophenolate, again, lifelong medication, something to be aware of as we're seeing these patients. And then your corticosteroids, prednisone, methylprednisolone. We have a couple different programs here. So some programs we can stop depending on the patient after a few days where we're tapering them down and then off. Or usually for most patients, we're going to taper down and then leave them on a consistent maintenance dose, low dose steroid. Now, lab draws are very important with our monitoring for our CNIs, specifically tacrolimus and cyclosporin. They're administered at 8 a.m. So we want to make sure that lab draw is done before 8 a.m. and getting it to our lab. So that way we can get these results back in a timely fashion, usually anywhere between 10 a.m. and noon. So that way we can make adjustments that day for our patients. Sirolimus and everolimus are two other immunosuppressants called mTOR inhibitors. Again, also given in the morning. For these, they have a little longer turnaround time, but we want to make sure, again, we're sending them appropriately and in a timely fashion to our lab. That way we can make these adjustments going forward. Other medications you may see, so I touched on the calcineurin inhibitors, the antimetabolites. Another one in that group is azathioprine. We just talked about the mammalian targeted rapamycin inhibitors, so those are your mTORs. On the kidney side, you may see belatacept, which is an infusion, usually given over 30 minutes. We use this in replace of sometimes our CNI or in combination with a low dose CNI. And then finally is the corticosteroids. And this was just a brief overview of the maintenance medications that these patients will be on and some of the medications that you're going to see on our transplant recipients. And now I'll hand it off to Melissa Hill.
So on to kidney transplantation. All right, so if you look at the volume we've done, 2021 to 2023, our program initiated in 2007, and we started with a mere 3. And our program has grown tremendously since then. So even in 2023, right now we're at 119, but our projected growth is going to be to 200. And if you look at these different colors, you can see the difference between living donor and deceased donor. All right, so this is just a little bit of overview in regards to kidney transplantation in the history. The first successful kidney transplant was performed in 1954 by Dr. Joseph E. Murray. And for renal transplantation, this is the treatment of choice. So for these patients that are at end-stage renal disease, you guys probably on your other units, you may see patients that are on hemodialysis or peritoneal dialysis. Treatment of choice will be ultimately renal transplantation if that's an option for them. Common diseases leading to end-stage renal disease include renal vascular disease, different infections, diabetes, hypertension, autoimmune conditions such as chronic glomerulonephritis and lupus, and genetic causes such as polycystic kidney disease and a number of inborn errors of metabolism. So even on your other units, you guys may see some of these different past medical histories within their patients. And, you know, in the future, these patients might be candidates for transplant. Kidney transplant is typically classified as deceased donor or living donor, and it all just depends on the source of the donor organ. Living donor recipients do have a higher success rate, both short and long term, and over 90% of living donor kidney recipients have immediate graft function as confirmed by urine production. The reason this is because when it's a deceased donor, they typically have what's called a longer cold ischemic time, which is in relation to how long the kidney is not receiving blood supply. The waiting time typically for these patients, it can be the following day or it can be weeks, months, years. It just totally depends. This is another reason why we really advocate if it's an option for our living donor cases with patients that you see that they may have end-stage renal disease, you see if maybe they have somebody in the family that could maybe test to see if they could be a potential donor for that patient. Other things that affect transplant time include how sick the patient is, how many donors are available within the area. I know that New York can be a little bit of a lengthy wait. Right now, for the waiting time for a kidney candidate is 3 to 5 years. But the 1-year survival rate for deceased transplant recipients is about 97%, and for living donors, it's around 99%. Living donor education, again, is very, very important and important to promote. This is just for the post-kidney transplant care and documentation. So for the patient care, if they come in as a deceased donor transplant, they will come up to 6 Monty, we'll pre-op them, then they'll be going down to, depending on the time of the surgery, they'll go to same day, they'll go to OR, and then they go to PACU and then 6 Monty. The surgery itself typically takes 4 to 6 hours. They then reside in the PACU for around 6 hours as well, and then they come to 6 Monty as long as everything goes well within the surgery. The average length of stay for these patients is 4 to 5 days. For documentation, the most crucial aspect of these patients is their I's and O's at this point. So with the Foley catheter, we're performing hourly I's and O's, and then we're checking their JP output as well. And then in regards to monitoring vital signs, when they first come to our unit, they'll be Q15s, and they go to Q30, and so on. And then monitoring lab work. While they're in the PACU, they do receive lab work before they come down to our unit, just to make sure that everything is looking good, that the creatinine is going in the right direction, and other electrolytes, including their potassium and different ones like that, are kind of within normal range. And depending on what that level is, they may receive HD immediately post-op, or they may just receive something like Lokelma or something of that nature. Renal Doppler is immediately done post-op. That's just to make sure that the kidney is patent and everything looks well with the transplanted kidney. We do glucose and finger stick monitoring as well. And this goes for both patients that are diabetic and also patients that are not diabetic, because they are on these high-dose steroids now. So it is going to inevitably increase their sugar. Venodynes, those are the compression socks. We're going to make sure they have those on at all times, as well as incentive spirometry. Every single patient, the second they come to 6 Monty, they receive a transplant booklet, they receive an incentive spirometer, and the PIS are on them immediately. And I think a lot of times they come from PACU like that as well, with the PIS ready to go. And I know on some of the units too, patients have fistula, so we're always going to avoid doing any blood pressures or placing an IV in that extremity. And ambulation and PT is huge. So post-op day 1, the second they wake up in the morning, we're getting them up, we're getting their weight, we're throwing them in the chair. You know, it's time to go. We have to get them moving, just to reduce post-op complications such as pneumonia and blood clots, things of that nature. And the cool thing with Six Monty currently is we have an ambulation project going, and we're pairing with PT to get all those fresh transplant patients up and moving. And then lastly is patient education. As I said before, they all receive a transplant booklet the second they come to our unit, and in SICU as well if they have a longer stay there. And that just goes over everything. Anything to expect post-op is all within that that booklet for them. That regards medications, what to expect, how to do their like post-care in regards to if they go home with a Foley catheter and all of that. It's all within that booklet. So we are making sure they're reading that and just going through that daily. That's the discharge booklets I just spoke of. They're getting continuous education from pharmacy, nutritionist. Every RN that has that patient will be going over education with them each time they receive the medication, as well as the rest of the transplant staff. It's important for the patient to learn how to self-administer medications. When they go home, they are going to receive a nice pill box, and they're going to be taught on discharge to fill out all of those pills themselves. So on discharge, we hand them the pill box, and we go through each, like every single medication they're going to be on, they have to put it into the pill box themselves and go through each and every one, because we want to make sure we're setting our patients up for success to avoid things like rejection and all of those things. Education provided regarding rejection surveillance, signs and symptoms of infection, lifestyle changes as needed. Some patients are going home on insulin that maybe previously were taking oral anti-diabetic agents, and long-term medication considerations, as well as follow-up visit schedules as well. And again, like I said, the pill box is going to be filled out with the family and patient on discharge as well. And then lastly, just some concerns post-op for kidney transplants. Bleeding, graft perfusion, which is again checked through ultrasound, delayed graft function, which we can sometimes see in our deceased donor population, and urine leaks, vascular complications, as well as rejection. So for our outcomes, it was expected to be 95.79% based on donor and recipient risk factors, but North Shore's 1-year actual post-transplant survival rate right now is 97.61%. And it is estimated that kidney patients transplanted at North Shore have a 39% lower risk of patient death at 1 year compared to the rest of the United States in their programs. And now I'm going to hand it over to Tatiana to speak on liver transplant.
Hello again. All right, liver transplant. So here's a graph depicting our growth. I know from the inception of the program, we've had over 500% growth. To date, we have 71 transplants for the year with a projected number of 100. To the right of the slide here, you'll see an Asian liver health program. One of our hepatologists, Dr. Park, and I believe Jamie and a couple others have been outreaching to the Asian communities in Queens, visiting primary care providers and GI doctor offices, and just gaining some insight and opinions on patients that are out there, and gathering information on what we can do to make the best of our program. Bottom right, we have our wonderful team there. Take a good look. They're world changers. Our little overview. So the first successful liver transplant with a patient surviving more than a year was performed in 1967 by Dr. Starzel. Liver transplant is now accepted as life-saving treatment modality for patients with both end-stage liver disease or acute liver failure. Unlike end-stage renal disease, there is no dialysis therapy for patients with end-stage liver disease. However, as I touched upon with the evaluation process, not all people are candidates for liver transplant. The MELD score, it's a scoring system that we use to prioritize deceased donor allocation for a liver transplant. The national average waiting time currently for a liver is 11 months. The MELD score has been used since 2002 in the US. It's a score calculating using the following lab values: sodium, creatinine, INR, total bilirubin, albumin, and female and male, which I just learned about recently, that females are given, I believe, 1 more point than males. I don't know the reason, I'm sorry. As the MELD score increases, patients' mortality risk also dramatically increases, hence a higher priority for liver transplant. Research has shown that patients with a MELD score higher than 40 had a 3-month mortality of 100%. Some patients would benefit from liver transplant. They do not necessarily have end-stage liver disease or have other complications of liver disease that are not considered in the MELD score. A MELD exception can be used. The most common reason for a MELD exception is HCC or hepatocellular carcinoma. Some of the common etiologies for a liver transplant evaluation. We kind of divided them into categories here. The viral etiologies of hepatitis, CMV, EBV, HSV, your chemical causes, alcohol, drug, toxins, metabolic issues there, NASH cirrhosis, autoimmune hepatitis, hereditary hemochromatosis, and cholestatic liver disease, such as PBC and PSC, malignancy, hepatocellular carcinoma, and there's a pediatric liver diseases as well, biliary atresia and primary alexuria. So for an indication for liver transplant evaluation, the patients with end-stage liver disease typically have a MELD score that is above 15. They have complications, ascites, encephalopathy, synthetic dysfunction, or variceal bleeding. Patients with acute liver failure are also candidates for liver transplant. These patients do not have chronic liver disease, but develop encephalopathy within 8 weeks and/or jaundice within 2 weeks of onset of liver injury. Since mortality in acute liver failure is high, these patients have a very short time frame to be evaluated, listed for transplantation before they become too sick to undergo liver transplant. They are listed using a special status 1 designation that gives them a higher priority than people with a higher MELD. And that's your incision. You'll see it's quite large. It's called the Mercedes-Benz chevron incision. Lots of staples. Post-liver transplant care and documentation. So surgery takes about 8 to 10 hours. So from the OR, they will go to SICU, be there for a couple of days. Once stabilized, they will come down to 6 Monty, and their average length of stay is 1 to 2 weeks. Documentation, in terms of nursing documentation, we're doing a lot of hemodynamic monitoring, same as with kidney patients. We're doing strict intakes and outputs. We're watching those vitals. And they're on pressors, that's more so for in situ, watching out for hypertension, vasodilation. We're doing constant lab work, sometimes twice a day. And just similar to the kidney patients, a liver Doppler, a Doppler is done immediately post-op on arrival to SICU. We're watching sugars because these patients are also on high dose of steroids. We're watching, once they come to us, they usually have 3 JP drains. So we're watching output. We're looking at color, color and consistency to be on the lookout for any signs of bleeding or a bile leak. They're also wearing their sequential compression devices at all times, using that intensive spirometer. And like Melissa touched upon, the ambulation project, great. We're minimizing that length of stay, getting them stronger to be able to go home versus rehab, et cetera. And doing a lot of education. So from admission, we're thinking about discharge. We're doing continuous education from the get-go, from nursing to pharmacy. It's a really great program. And we have those discharge booklets and a pillbox. That's probably the most important. We send off these patients to home, making sure they are ready to go, answering any and all questions. And we have a wonderful clinic that takes care of our patients post-op and checks in whenever they need. Early post-operative complications, primary graft non-function, probably the most emergent. It's needs for a retransplantation right away. Poor early graft function, hepatic artery thrombosis, portal vein thrombosis, bile leak, and bleeding. Some long-term complications following liver transplantation, side effects of all those immunosuppression medications. Some are listed here: hypertension, diabetes, GI upset, hyperlipidemia, et cetera. Osteoporosis, that's why we send them on a calcium supplement as well. They're immunosuppressed, so they're at higher risk for opportunistic infections, PCP, HSV, fungal infections, et cetera, and malignancies, PTLD, and skin cancers. At North Shore University Hospital, our 1-year actual post-transplant survival is 97.3%. It was expected to be 93.7% based on our donor and recipient risk factors. I'm going to hand it off now to heart transplant.
Hi, everyone. My name is Jamie. I'm one of the heart transplant coordinators. Going to be talking to you a little bit about our transplant program. So this is our multidisciplinary heart transplant team. We have our surgeons, Dr. Zach Kahn is the surgical director of transplant, and our cardiologists. Dr. Garen Stevens is our system director, and Dr. Maria Avila is our medical director for heart transplant at North Shore. But as you can see, we're made up of a large team, RNs, NPs, PAs. We have pharmacists, social workers, psychologists, nutrition. It requires a strong collaborative team to really provide the best patient care. Also, you'll notice the phone number at the bottom. It's our transplant phone. It's carried by myself, Senior Transplant Coordinator Catherine Malamy, and our heart failure supervisor, Dora Rossi, and we're available 24/7 to patients and clinical staff as needed. Our heart transplant program at North Shore was started 5 years ago in 2018. We transplanted 14 patients that year and also in 2019, and we've had steady growth in volume each subsequent year. In 2020, we performed our first dual organ transplant, which was a heart kidney. And last year, we performed 4 heart-lung transplants. There were actually only 52 heart-lung transplants total performed in the US in 2022. So we did 10% of the national volume here at this hospital. Last year was also our first triple organ transplant, heart, lung, kidney. And this year in January of 2023, we reached a really exciting milestone. It was our 100th patient, a dual organ recipient, heart, liver. And today we are up to 115 transplants total and growing. So when a patient is determined to be a heart transplant candidate, they are placed on a wait list. The patient's assigned a status based on their current clinical condition, and that status determines their position on the list. Essentially, you'll see, the lower the status, the sicker the patient. So they have a greater medical urgency for transplant and they need to be prioritized. So they'll be higher on the wait list. But it's important to note that waitlist time for heart transplant depends on several factors, not just status. Unfortunately, we're not just picking hearts out of a vending machine. We need to look at the patient's blood type, body size. So wait time is not something we can completely control. And it can really vary based on hours to days, even months to years. You'll see the national average wait time for a heart transplant is 4 months. When we do assign a status, though, you'll notice that status 1 through 3 patients, they're sicker, they do require hospitalization and a varying amount of support. Status 1 patients may be on ECMO, they can have life-threatening arrhythmias, even despite all the support that we're providing. And then, status 3 patients, you'll see they need high-dose inotropes and continuous monitoring, so they do need to be hospitalized. When you get to status 4 through 6, these patients are a little more stable. They're able to be discharged. They can go home on inotropes with an LVAD or oral medications. And then status 7 patients are listed, but they're currently inactive due to some factor that's prohibiting transplant at this time, such as infection. So when we're considering a patient for heart transplant, we need to keep in mind that heart failure can be a progressive disease. There are different stages. From early on, our goals are always to prevent symptoms and prevent further cardiac remodeling. And then beyond this, we can use guideline-directed medical therapy, GDMT. You could see these patients on, Lasix, beta blocker, ACE inhibitor. We're doing this to really try to manage their symptoms and prevent hospitalization. So fortunately, most patients do really respond to these therapies, but for some, we can reach a point when heart failure progresses to that stage D, you'll see at the end, and then the symptoms are persisting or worsening despite GDMT. So that I need help mnemonic kind of highlights the markers of advanced heart failure. I'll mention inotropes, low EF, hypotension, and organ dysfunction. And at this point, these are the patients that we're starting to evaluate for advanced therapies and heart transplant candidacy. In terms of outcome, you can see at the bottom left, our transplant program survival percentage at different time frames is slightly above the national average. In regards to longer term outcomes, if you look at that far graph, and the blue line is representing primary heart transplant, we have 50%, there's 50% survival, patient survival at 14 years post-transplant. So at some point, all of you may find yourselves taking care of a heart transplant patient. Maybe you have already. Immediately post-transplant, our patients move from the OR to the CTU. And then once stable enough, they're transferring out to the step-down unit or to Cohen, and then they can be discharged to home or rehab based on their needs. Our patients' average length of stay is about 21 days. This is a little shorter than the regional national average, which is 25 days. And the whole time, we're really emphasizing the importance of direct patient care and ongoing education. Our goal is always to prevent rejection and infection. So this requires really close vital sign monitoring, checking the immunosuppression or prograf levels at the appropriate times, which is 1 hour before giving medications, which, as mentioned before, are also specifically timed. And then patient education is a major focus. Heart transplant is such a gift, but there's like a lot to learn for the patients. It's a lot of new medications. It's a really strict regimen, lifestyle changes, dietary infection precautions. So our team does the bulk of the transplant education, but it's really so helpful for everyone involved in their care to kind of reinforce and educate when they can, especially if the patient is new to insulin. Insulin teaching is so helpful, and also providing discharge instructions. Just want to say our team is really very proud of our program so far, and we're excited for the future. But without you and all of your help and your excellent care of our patients, that wouldn't be possible. So we really do thank you for everything you do for our patients. Next, we're going to talk about lung transplant. Yes.
Hi, thank you for being here. My name is Jong Yoon Kim. I'm a staff nurse at cardiothoracic unit. We are ICU, so we take care of a patient who had a heart and transplant surgery immediately after the surgery. This is a lung transplant number. This number is it's same like a heart transplant team. These numbers work 24/7, 24 hours and 7 days. Okay, so let me introduce our lung transplant team. Dr. Akano, he's our medical director and our lung transplant team. And Dr. Khan, he's our surgical director of heart and lung transplant. And we have a pulmonologist, Dr. Korotun, and Dr. Hassan, and Dr. Makar. And the pictures are not here, but we have a Dr. Sekas, and who's a surgeon, and Dr. Haddad also, he's a surgeon. And in addition, we have ACP staff like PAs, and we have MP, and we have RN, we have our pharmacist, and we have a social worker, and we have a clinical coordinator, and we have a secretarial support. Okay, so this is our lung transplant volume since 2022. So in 2022, we had a total 11 numbers of a lung transplant patient. And as of now, in 2023, we have already reached to 10 patients now. So you can see progressive growth in this volume. And now currently the total 18 number of patients is open evaluation, which means they are still on the workup process to get data for their evaluation. And also we have total 11 numbers of patients waiting on the waiting list. And hopefully they will get, the lung soon. And we have so far we have a total 21 numbers of post-transplant patients. So the next topic is pre-lung transplant consideration. So the reason for the lung transplant is progressive lung disease such as COPD and interstitial lung disease and cystic fibrosis and COPD or severe pulmonary hypertension, which impact their quality of life. And so when we have a lung transplant, we have an evaluation process, same like other organs. So first, patient referred to lung transplant team. And as an initial intake, we send the financial evaluation to the patient, maybe the social workers. And we need a consent education before starting evaluation process. And lung transplant team, we do have a lot of the workup, process compared with other lung, or the other organ transplant because to get a, because lung is we need more like a lot of information and data to successful lung transplant. And same like other, we have a multidisciplinary clinic and we have a selection committee meetings. So average time of waiting list is 6 to 9 months, and median transplant survival rate is 6.7 years. And lung transplant has special allocation system. The name is composite allocation system. So the average score is 20 to 30. So I'm going to talk about composite allocation scoring system, which is starting since March 2023. This is a new lung allocation system to reduce the wait list mortality. So CAS system has several factors to evaluate candidates. So each factors have a certain amount of points. So maximum points are 100. So the patient have the highest point for the given donor will be the first to get organ offers. So the CAS factors are the medical urgency. It has 25 points, which is the highest points. And then there are expected 5-year post-transplant survivor. And we have immune system matching factors such as height and blood type. And if patient is a pediatric which is younger than 18 years old, they can get 20 points. And we have if the patient is a prior living donor, they can have 5 points. And also there are factors for travel efficiency and proximity efficiency. The travel efficiency means how efficient it is to transport the lung from donor hospital to the transplant hospital. And also proximity efficiency means the distance between donor hospital and then transplant hospital. So total 10 points are given to travel and proximity efficiency. So, sorry, and then there are some few considerations before consenting. And if patient had a cancer within the last 5 years, we need a further investigation. If the cancer was stage 1 or it is surgically removed, patient can be on the list. But if the cancer was stage 2 to 3 or if they need a treatment, we have to wait for the treatment for the cancer. If a BMI is greater than 34, we would refer patient to the body weight control management first. And if patient is smoking within the last 6 months, we have to send the patient to specialist to stop the smoking first. And then history of cardiac surgery and chest surgery and radiation, it can be one of the consideration for the prior consenting. And the right side is the workup list before the lung transplant. So as I said before, the lung transplant has the most needs a lot of the information before the evaluation process. Okay, so these are the transplant patient monitoring. So we continuously monitor patients in various stages of the patients. For the evaluation, which is a pre-transplant, we need the consent class and we need the appointments every 4 to 6 weeks. And if the lab results are abnormal, we refer patient out to the specialist to for the further management. And for patient on waiting list, we need appointments every 4 to 6 weeks. 6 weeks for the blood works and chest X-ray and pulmonary function test and 60 minutes walk test. So if there is any change or if any clinical findings, the lung transplant coordinator will update the nurse system. And if patient is after transplant, if patient has any rejection symptoms or signs of infection, patient will be readmitted to Cohen or CTU. And also if after bronchoscopy, if there is any respiratory distress symptoms, patient will be admitted too. And post-transplant, upon discharge, patient receive a scheduled follow-up visit and procedure for next 6 to 8 weeks. So patient need to every week office visit for first 6 weeks. And also they need a pulmonary function test for every week for 6 weeks. And then after that, after 6 weeks, then the labs will be like titrate down the bi-weekly, then monthly. And surveillance bronchoscopy will be done first, third, and sixth, and ninth 12 months after transplant, and if needed, clinically if needed. Okay, so post-lung transplant care documentation. So surgery takes usually 6 to 12 hours depending on single or double lung transplant. After surgery, patient will be admitted to a cardiac CTU. And then in CTU, if patient condition is stable enough, patient will be stepped down unit into Cohen. Average length of stay for lungs is 3 weeks, and heart and lung transplant is 3 to 4 weeks. So we monitor patients' vital signs and intake output, especially from the chest tube. We monitor any bleeding or ailing. And we monitor lab values, especially prograph levels, and timing is important. We monitor signs of rejection and infection. And we have to monitor the pulmonary function tests complete by a respiratory therapist. And we need early ambulation and aggressive lung hygiene is a key, important factor to recovery. Collaboration with the medical staff and nurse and physical therapy. For the discharge teaching, education start at the initial consult for the lung transplant, continuous transplant process, education provided by pharmacy, nutrition, and physiotherapists and medical staff. For CMS guideline, formal discharge education to be completed within 24 to 48 hours of discharge, and it should be documented. Okay, so next is operating room consideration. So as everybody knows, the correct patient identification and donor identification is important. So after surgeon accepts the organ, donor coordinator sends out the notification email to respective organ team, and donor coordinator and or management coordinate or time and team. And surgeon keeps the OR updated based on the organ recovery. And 2 transplant team members must perform the verification matching patient's wristband and the organ verification form from UNOS. And then patient will be prepared for surgery by surgical staff. And once the organ arrives, the check-in process at front desk must be done by nurse and recovery surgeon. If anything incorrect, they contact OPO, which is the organ procurement organization, and surgeon immediately. And also before opening the transport box, there should be one more ABOM verification process. After that, there will be additional check for correct organ and correct patient before actual implantation. So after that, the organ is ready for implantation. That's all from me. I will hand off to Rebecca from Livon.
Hello, I'll be really quick. I am your Senior Hospital Services Specialist from Livon. This is Dr. Abraham Warshaw. He is the CMO of Livon. So I am going to just go into really quickly how these organs get to you, the transplant teams. So I passed out in the back, there's some clinical trigger cards of what is required for you to refer a patient. So that way we can implant those organs. So thanks to our hospitals, our team members, and the generosity of others, we've had hundreds of lives saved. 1,300 organs were transplanted last year from Livon, New York. The Northwell Health System had 63 organ donors and 147 tissue. In 2022, North Shore had 21 organ donors, resulting in 51 transplanted organs, an average of 2.43 organs transplanted per donor, well over the national average. The impact of these donations resulted in 29 kidney, 14 liver, 2 heart, 6 lung transplants. And most of these organ donors were inpatient from the NSCU, SICU, MICU, neonatal ICU, and the CICU. So the impact on transplantation that North Shore has had so far this year, our numbers are a bit down. We've had 3 organ donors so far this year. We had our 4th one last 2 days ago. So far we have resulted in 6 transplanted organs, an average of 2 organs transplanted per donor, with 3 kidney transplants, 2 livers, and 1 heart. So when are you referring your patients to Livon, New York for our patient, for anyone on any of these floors? Within 1 hour of every cardiac death that occurs in this hospital, that has to be referred to Livon, New York. Those are your potential tissue donors. You're going to also be referring any mechanically vented patient that meets any of these conditions. So that's an absence of 2 or more brainstem reflexes, a GCS of 5 or less, and prior to any end-of-life discussion with the patient's family. So if you know that a goals of care meeting is going to be held tomorrow and we're going to be discussing a palliative extubation, the phone call has to come in today. So we have enough time to evaluate the patient and see if the patient is on the organ registry. So these should all be documented in the initial organ donor referral note. You can use keywords like organ referral or donation when searching for this document. And all cardiac deaths should be documented in the discharge note for the expired patient. So again, these are on those little badge buddies back there. Please use them. And then something special that we do for all of our patients whose families give consent, we do something called Code Starlight or an honor walk. It is a way to honor what this person is about to give and the gifts that they're about to give and honor their family as well. So any staff that wants to participate will be notified of where they can go. So whether it's up at the SICU or the MICU, there will be an email that's sent out and they will call a code Starlight. So anyone who wants to attend can attend. And I'm going to let Dr. Warshaw go really quickly over the pathways of organ donation. So that way you can go ahead and then transplant them.
Great, great. Thank you very much. Did want to take some time to go over the different types of donors that can give the gift of life through organ donation. Just first, I want to say that we recognize, Live On New York recognizes the importance of nursing, RNs, NPs, PAs, and the whole team, starting with the referral process, the management of the donor, the work that's done in the OR, not to mention all the work that's done for the recipients. And we'll do everything we can to collaborate, advance education, and do whatever we can to talk about the process and optimize it. Also, it's great to see that you have such physician support here, and Dr. Momente is a very frequent visitor to our ORs, and we sometimes speak right in the OR. So great, great surgeon, great advocate for donation and transplantation. So great to meet you. So it was mentioned earlier that there's sort of 2 types of donation. There's a living donation and the deceased donor donation. So what I'll talk about is the 2 types of deceased donor donation. So the most common type is brain death donation, and brain death by the state is defined as actual death. Anybody who is actually brain dead, they're not coming back. They're clearly brain dead, and they become, if they're either on the registry or the family consents, if the patient had not been on the registry as a donor and they are brain dead, they can be candidates for donation, based on their medical condition, on what organs, could be potential. Now, it's really important, of course, that you make sure that the patient is brain dead. So we do a number of things. Number one, when the patient comes in and we have a referral, we stop and say, why is this patient acting, brain dead? Did they have a big stroke? Did they have an anoxic event such as an MI or an overdose that caused an anoxic event? What could have caused that? If the patient doesn't have a reason for having a brain death or having some kind of neurological insult, we stop and say, what could else? Are they hypothermic? Are they on a long-acting barbiturate? Is there another reason? So I wanted to be clear, and we make it clear always that we make sure that we have a reason and that we make sure the patient is potentially brain dead. Then when an exam occurs and the patient has no more brainstem reflexes, they're not overbreathing the vent, they're appearing brain dead, there are tests that are done, either apnea testing or ancillary testing that assures that the patient is brain dead, before we go ahead and do the donation. And most cases, up to around 60 to 70% now, depending on where you are brain dead donors. However, what happens in many cases, as you know, patients can have a huge neurological insult, a stroke, a anoxic event, but they're really never going to be brain dead. They'll have a few brainstem reflexes, and then what's going to happen with that patient? Well, there's a few options. Usually, sometimes based on patient wishes or the family wishes, the patients will be stabilized, pegged, trached, and then sent to a long-term care facility or the like. Sometimes the family will decide that they want to withdraw care because they realize that there's not a quality of life. And in that case, we might approach the family to talk about a second type of donation called donation after circulatory death. In that case, the patient is already DNR, they're under palliative care, and there's still an opportunity for that patient to donate by this pathway. Now, of course, the patient is not dead yet, they're alive. So we do not recover on live patients. So in this circumstance, DCD, donation after circulatory death, the patient is taken to the OR and they are extubated. And then we wait. Each hospital has a different amount of time. In the case of this hospital, we wait 120 minutes to see if the patient expires. If the patient does expire, then we're able to commence with recovery of the organs. If the patient does not expire, they're taken back to the unit, not reintubated, and then given palliative care until they do expire a cardiac death. DCD is a rapidly increasing sort of methodology where people are able to give the gift of life, and we are able to procure more organs. In 30% of the cases that we take a patient in the OR, they do not expire. But when they do, we are able to procure. There are certain challenges. There is, as mentioned, ischemic time, where if a patient has too much ischemic time, there's risk to the biliary tree and the like, in the liver, for example. So that's taken into consideration when we consider who can do that procedure. And we rely on the surgeons to efficiently recover those organs to decrease that. So that is the second methodology, DCD. And just one thing, just on your radar to mention quickly, some DCD patients are, when they go to the OR and they're extubated and they expire, some patients, there's a relatively new procedure called NRP, which is normothermic regional perfusion. It's before we recover, the patients are placed on ECMO in order to reperfuse the organs and increase the chance that there will not be ischemic damage, and then the organs are recovered. So just a whole nother topic to discuss, but want to put on your radar since you might be hearing about that in the future. So again, any questions that in the future, any concerns, we're always available. And look forward to working with you and congratulate all of Northwell on the incredible success they've had, in their transplant program.
So this is literally just an overview of some of the patients we've transplanted. On the left here, you're going to see a kidney living case. In the middle is going to be heart. And on the other side, you're going to see a deceased donor. And lastly, thank you so much for all of your time today. I know this is a very information-rich PowerPoint. Does anyone have any questions for anyone here in the crowd, the panel, anyone? All right. Thank you again so much.